Today I'm going to discuss visual acuity outcomes and anti-VEGF intensity in a real-world analysis of nearly 30,000 eyes. My disclosures are shown on this slide, none of which are relevant to this presentation. I have previously presented and published on clinical practice outcomes in neovascular AMD, DME, and RVO-associated macular edema. In one of these studies, we assess outcomes with anti-VEGF therapy and diabetic macular edema. In the 12-month cohort, there were nearly 6,000 eyes. They received a mean of 7.8 injections and gained a mean of 5.2 letters. Mean change in vision over time is shown for each cohort. Each group gained approximately 3 to 6 letters. In these studies, we use the Vestrum Health Retina database, with which many of you are familiar. In brief, this database aggregates de-identified data from hundreds of U.S. retina specialists and includes data from 2.3 million patients. The formula shown here was used to convert Snellen visual acuity into an ETDRS approximation, but this obviously can't compare to a standardized ETDRS protocol refraction. In the current study, we sought to answer the question, how does treatment intensity affect outcomes at 12 months? We increased the sample size and modified the eligibility criteria. Specifically, there was no requirement for induction with 3 or more monthly injections in the first 4 months. In terms of demographics, there were nearly 30,000 eyes. Approximately half were male and half were female. Approximately half of the patients received bevacizumab as initial therapy, and the other half was split between aflibercept and ranibizumab. How were injections per year per eye distributed? The number of injections per patient in the first year ranged from 1 to 13. The median number of injections per patient eye was 6. The distribution of injections per patient eye was skewed towards the lower range. Approximately 50% of eyes received 6 or fewer injections, and approximately 20% of eyes received 10 to 13 injections, representing monthly treatment over this 1-year time period. Baseline visual acuity did not correlate to treatment intensity. In other words, those who received few or many injections were not necessarily better or worse at baseline. With regard to top-line results, at 12 months, the mean number of injections was 6.4, and the mean change in visual acuity was 4.2 letters. There were no meaningful differences in outcomes based on initial anti-VEGF agent. Real-world DME eyes with worse baseline visual acuity gained more vision than those with better baseline visual acuity. The eyes were stratified by baseline visual acuity in one analysis. They received a similar number of injections. Those with the best visual acuity tended to lose vision, and vice versa, demonstrating a ceiling effect. The change in visual acuity versus injections over 12 months is shown. This shows 2 distinct themes. First, eyes which received fewer than 5 injections in 1 year improved minimally, gaining approximately 2 letters at 1 year. Second, there appears to be a linear relationship between the mean number of injections and the mean letters improved over 1 year. Eyes with good baseline visual acuity, 20/40 or better, generally lost vision unless they received intense therapy. Those with moderately severe baseline impairment, 20/70 to 2200, who received 10 or more injections in 1 year improved by a mean of 10.3 letters, which is reassuring. Colleagues tell me that their results are better, or that other studies show better results. However, it's simply not true. The results are similar to prior smaller studies shown here. In summary, real-world DME patient eyes experience only a modest gain in visual acuity at 1 year. Better baseline visual acuity increases the risk of vision loss. Injection frequency plays a large role in visual acuity outcomes. Real-world DME patient eyes receive approximately 6 versus 9 injections across well-known randomized controlled trials. Real-world outcomes are worse than in randomized controlled trials by approximately 1 line of vision overall and 2 lines of vision for those with good baseline visual acuity. This paper has been published in the British Journal of Ophthalmology and is freely downloadable. Thank you very much for your interest.